Hello and welcome back to the Oncology Brothers podcast. I am Rahul Gosain, and along with my brother and co-host Rohit Gosain, we're thrilled to have you join us once again. Today, we're diving into the world of small cell lung cancer with our guest, Dr. Eric Singhi, a thoracic medical oncologist from MD Anderson Cancer Center. Eric, it's a pleasure to have you here with us today.
Thanks, Rohit. Thanks, Rahul. Always excited to talk with you guys.
Eric, welcome. Let's start off with limited stage. But before we even dive into the treatment algorithm, the thing that we don't get to see in our clinic that often is this patient population of less than 5 centimeter and no nodal involvement, particularly in small cell lung cancer. So, how do you really manage these patients here, especially given the fact that this is not a common presentation?
Yeah, I think you're absolutely right. You're spot on. So this is really the patient that unfortunately we would love to see in our clinic more often, right? To be able to very aggressively approach this treatment with a curative intent, but it's just not the typical find. So in general, limited stage occurs in about 1/3 of patients with small cell lung cancer. This is even more of a rare finding. So if patients have a very small primary tumor, node negative disease, we absolutely want to assess with our multidisciplinary colleagues if they're a good surgical candidate, if the surgical resection is going to be meaningful for the patient. And then after surgery is done, a very thorough postoperative pathology review followed by adjuvant platinum-based therapy, as you wrote there.
Eric, any role of PCI in this early stage?
I think that's a really good question. Just in general, sort of the concept of PCI now, where are we at and what are we doing? So you guys know I'm a very big believer in shared decision-making in clinic with all of my patients in general. And so you really need to talk with your patients about the pros and cons of PCI and really make sure they have the opportunity not only to meet you as medical oncologists, but to meet the radiation oncologist too. So a lot of our data from PCI comes from some of the trials that were done in the late 1990s, early 2000s, where initially it looked like we were seeing nice clinical benefit from the use of PCI in the extensive stage setting, also limited stage setting. But we started to call that a little bit into question. What those studies, were we really using the appropriate, most detailed sort of brain imaging, which is an MRI brain, for surveillance, for continued monitoring? So I have those nuanced discussions with my patients in clinic each time. I say, hey, listen, this is the information that we have. These are the potential pros and cons of PCI, but you also should meet my radiation oncology colleague and we should talk it through together.
And there's no right or wrong answer here, and we'll keep coming back to this idea of PCI throughout this discussion. So thank you for touching on that. But moving on to something that's unfortunately more common, larger tumor or lymph node involvement, but still sticking with that limited stage. Eric, thoughts here? And can you also touch on the recent Adriatic data from ASCO 2024? Durvalumab is not yet approved, but this data is certainly practice changing. Have you prescribed this already since you've been back in your clinic from ASCO? What is it looking like?
Yeah, I'll first touch on sort of the historical context of what we've been doing for our patients, and you've highlighted it very nicely here in your algorithm. So these larger tumors with sort of node positive disease, which is more of the classical presentation of limited stage small cell lung cancer. I think, it's really nice to be able to explain to trainees just in general how we stage small cell lung cancer. It's a lot more clinically practical, right? So you either have limited stage where the disease is on one side of the chest with lymph node involvement oftentimes, or you have extensive stage disease where it's more than that and it can't be treated in a single radiation field. So that first sort of former description is really what you guys are showing here on that top half, and that's limited stage. And we really do recommend pursuing an aggressive treatment, which is concurrent chemoradiation therapy with a platinum-based concurrent regimen. And it's not an easy therapy. We really need to make sure our patients are supported throughout the treatment. It's been the standard of care for almost 40 years, which is wild to think about, right? That we haven't really made too many exciting changes for our patients with limited stage disease until, like you said, the exciting findings from Adriatic study at ASCO 2024. So the Adriatic study, definitely practice changing in my opinion. A lot of us were very excited to hear it discussed at the plenary session. A lot of us have rebranded ASCO 24 as ASCO Lung. That's how exciting these findings are, So I think one of the hardest challenges, and it's almost heartbreaking to see, is if you think about patients that historically have gone through definitive intent concurrent chemoradiation for limited stage disease, and you look at 5-year overall survival rates. So What are those patients doing? Where are they at with regards to outcomes 5 years after finishing grueling chemoradiation? Unfortunately, 65 to 70% of those patients are no longer with us. And so obviously there's an unmet need that we need to fill. And that's where I think the Adriatic study came in very nicely. So this study basically enrolled patients after completion of concurrent chemoradiation therapy to either durvalumab or placebo. There was another arm that's unblinded for right now, and that includes CTLA-4 blockade with tremelimumab. But the focus at ASCO was looking at durvalumab consolidation for 2 years or placebo. And what we saw was not only a progression-free survival benefit, but an overall survival benefit of almost 2 years, which is pretty incredible, right? It went from 33 months to 55 months.
Yes. Yes.
Absolutely huge. And if I have a patient that I'm seeing after, the Monday from ASCO, absolutely 100% durvalumab is on my radar to discuss with them.
Rightly, Eric, you couldn't have summarized it better. It is practice changing starting yesterday itself. And it's amazing that how thoracic medical oncologists don't stop rubbing in how it is ASCO lung. Well, thank you so much for covering that, Eric. We've briefly talked about PCI, but the question is, after the Adriatic data, how are we going to incorporate PCI? Because we've seen the data that the immunotherapy should be rightly started after concurrent chemoradiation therapy with very little gap. We've seen the similar data in non-small cell lung cancer with Pacific data as well. So where exactly are you going to be incorporating PCI given the short time frame that we have to start immunotherapy right after concurrent chemo?
Yeah, I think that's a really good question. I don't have the exact answer yet. I still definitely encourage multidisciplinary discussion, making sure patients really understand what's involved with PCI. So we'll definitely be sending them to my colleagues in radiation oncology to discuss. But another concept here too is, immunotherapy, it can penetrate the blood-brain barrier at times too, right? And so, this is the question. We don't have really good data
Right.
to kind of guide us in this space. So
Very true.
I don't have a perfect answer, but I think it's going to be individualized sort of decision making.
And again, can't stress the importance of multidisciplinary approach, especially if one does not have these available at their facility, diving into the tertiary and quaternary centers around. Now, Adriatic data is certainly practice changing as we've delved into. Now, these patients, if they are to progress on durvalumab or less than 6 to 12 months after completing durvalumab, Eric, thoughts on first line of treatment in your current approach in recurrent disease and extensive stage?
Yeah, I think you hinted on it nicely, really thinking about what we define as platinum sensitivity. So, conventionally, it can kind of vary. So overseas, more of our European colleagues, they even consider 3 months or less to be platinum sensitive. But conventionally here, it tends to be more about 6 months or so. So I think first I would say it depends on really the timing that you're concerned that your patient is progressing. And then second, the extent of progression. And if it includes intracranial sites, extracranial disease. I think it's also going to be a very individualized sort of decision making based on those two factors. But I would venture to say that if the patient is more than 6 months out from platinum exposure, it is still reasonable to consider re-challenging them with platinum-based therapy, whether with or without immunotherapy. That's definitely a question that's pretty valid here. But certainly definitely different options. And I know you have the extensive stage algorithm there below. So I would really tap into those. And then, of course, clinical trials.
Yeah, I think clinical trials ends up being very important, not just here in small cell lung cancer, but anytime we're seeing a patient. But coming back to this idea of immunotherapy, and especially post-Adriatic, right? If a patient has been exposed to immunotherapy, your current line, as we can see here, is atezo or durvalumab with our platinum agents. It's tough to say what next 2 or 3 years are going to look like once our patients have been exposed. Are we going to continue with atezo? Are we going to continue with durva in the settings? We've seen some data from GU that when you're exposed to a second immunotherapy after being exposed to something upfront, it did not show any promising response. So we just have to be mindful of that.
I think we have the same question too in non-small cell lung cancer, right? We're moving immunotherapy into the perioperative setting, neoadjuvant setting, or adjuvant setting. And so we're going to have the same questions here. What should we do with immunotherapy if our patient does unfortunately experience progression or recurrence of their disease? So I think more to come. Definitely should be validated and studied in a prospective manner. But for now, I'm still just so excited that we finally moved
have something.
Indeed.
Thing.
Yep.
Eric, when we're touching on extensive stage, when you're starting a patient on this combination chemotherapy with immunotherapy, can you talk to us a little more about the use of Trilaciclib in your clinic for extensive stage? Are you using it for all your patients up front, or what does that look like?
Yeah, so Trilaciclib, for those that don't know, it's a CDK4, CDK6 inhibitor. You usually give it about as a 30-minute IV infusion. It's completed on each day that chemotherapy is administered. So you have to give it each day. That's something to make aware. Personally, I have not used it in my practice, but I've actually discussed the use with several different colleagues from around the nation. And it's interesting to always see just differences in clinical practice, right? And what we're doing for our patients and to talk that out with my colleagues. So personally, I haven't used it, but the approval was really based on a pooled analysis of 3 different small randomized phase 2 trials, which Trilaciclib or placebo was given either in a platinum-based regimen or with topotecan. And it did show that there were lower frequencies of chemotherapy-induced myelosuppression, so less anemia, thrombocytopenia, neutropenia when they did give Trilaciclib. It did not impact efficacy. It did not make a change in overall survival, so that's definitely important to keep in mind. But it absolutely did show benefits in health-related quality of life, and there was less of a need for supportive transfusions, and it did not affect, again, the efficacy of the therapies that were given to patients against the small cell. So I think it's a nice addition to our toolbox. There's other factors that we can use, no pun intended, but growth factor, right? Like GCSF, we can consider that as an option. But I think thinking about cost, thinking about some of the different institutional differences, and then discussing the options with your patients, it's a very valid approach.
And talking about the growth factors, Eric, do you incorporate these growth factors right off the bat when you're using extensive stage carboplatin etoposide? Again, there are some practices who have this part of their order set, but again, just wanted to see and hear your take on that.
Not always. I kind of think a little bit about the patient and their
Right.
comorbidities and sort of what their age is as well. So I don't always give it,
Okay.
but I don't think it's a wrong practice. I think
Right.
that it's individualized.
Patient was started on systemic treatment. Now they've had good response. It's also important to keep in mind to consider consolidation radiation to the primary site. So that at times can get forgotten if patient has excellent response. But even before Tarlatamab, we have Lurbinectedin. And even that has not been a home run. Very marginal improvement. Eric, can you touch on this a little in your clinical settings? And are you using Lurbinectedin before Tarlatamab? Are you going to use it after? What are your thoughts here?
Yeah, I think that's a good question. So lurbinectedin, it's a DNA alkylating agent. We kind of heard about it a few years ago. I am still using it. I have personally seen responses in some of my patients. And from ASCO 2022, I believe, if I remember, we saw some data from the Atlantis trial that showed that there was a subset of patients that got through the doxorubicin, lurbinectedin, and then continued on lurbinectedin monotherapy for like 20 months of median overall survival, which is pretty incredible. So there seems to be maybe a subset of patients that actually do get a response to lurbinectedin. So I wouldn't throw it out the window just yet. But I do think, it's going to be utilized. It's easier as well from the clinic flow and sort of administration process as we're still all collectively learning how to give Tarlatamab efficiently and safely to our patients. So I would say, keep it in your toolbox. Any tool that we can keep for our small cell lung cancer patients, we should definitely keep it. And I have seen responses in patients, whether they're platinum sensitive or platinum resistant.
I want to reiterate that by no means lurbinectedin is out of the picture here. This is still one of our standard of care second line treatment options because we don't have too many options here, exactly to what Eric you've said. We have to use everything in that toolbox.
And another exciting change from small cell, Tarlatamab. This drug was recently approved by FDA based on a small study, 99 patients, after we saw 40% overall response rate. But there is an important black box warning about CRS. Eric, what is your workflow today in administering Tarlatamab? Especially, it is important for our community folks because one has to be monitored here for 24 hours. How are you partnering up with your community oncologist in this setting?
I think you're asking the perfect question, and we're still actively trying to figure it out, to be honest. It's such a fresh, recent FDA approval that requires a lot of planning, right? You hinted on the inpatient portion, which is so vital and important because a lot of us solid tumor oncologists are not comfortable with one of the most common adverse events from this treatment, which is cytokine release syndrome. And so I think just to kind of talk a little bit about the drug, Tarlatamab, it's a bispecific DLL3 CD3 T cell engager. We first heard about the data at ESMO last year. And most patients have gotten at least 2 treatments or more for small cell lung cancer. And like you said, the objective response rate was 40%, which is pretty impressive to see that response rate in patients that have been previously treated. I think with this, we really need to have good education for the patients, good education for the providers at academic centers, providers at the community center. You do need to have that 24-hour monitoring for the CRS, and it can be a very unique sort of side effect profile to manage, right? I think one of the nice things about it, though, is that it tends to be pretty predictable. So when you look into the trial data, the occurrence of it, the median onset was around 13 hours during that cycle 1, day 1. So it seems to be very predictable, and it seems to be mostly grade 1 to grade 2. So you can get away with more supportive measures for our patients, like fluids and acetaminophen and steroids, less having to tap into tocilizumab and some of those other drugs that we just don't use very commonly, right?
Right.
But yeah.
Yeah, and again, in the community, I think partnering up with the tertiary or quaternary center where you can have these 24 hours ops. And this is not just unique to small cell. We've started to see a whole lot more of this play out in the heme malignancy side of things. So again, that multi-D partnering up with the right team is so important. We've touched on PCI in limited stage.
Yeah, I think that's the million-dollar question. Obviously, it's under investigation with the SWOG study and the Maverick study, right, to kind of figure out what's the best approach. I had been having lately a lot of detailed conversations in clinic with the patients, and we talk a little bit about what PCI may look like, what the experience may look like, and then some of the data that came out, obviously, from the Japanese trial, where we saw actually maybe that benefit we used to think was present with PCI may not be the case. And I will tell you, for the most part, my patients now have been leaning towards actually MRI brain surveillance, very close scheduled MRI brain surveillance, but that seems to be more of a trend here. But I still think you should have that conversation with each patient, present, the 3 trials that we have, discuss the Maverick study as well that may be coming here with some updated information. But until we get that 100%, I don't think we can be fully prescriptive with which way is the right way.
And again, a lot of these trials that were done previously did not involve immunotherapy. And now, as you mentioned previously, that some of it does cross the blood-brain barrier. So we don't really know whether the advantage is still the same, whether that's limited stage or extensive stage for that matter.
Absolutely. Yeah, I agree with that.
Before we close, I'm going to briefly touch on another rare subset, a patient that has a disease with a driver mutation, but has small cell clone or conversion. In that particular scenario, do you add chemo with immunotherapy or continue on with their targeted agent and then add chemo in addition to that?
Yeah, I think this is an active sort of area of research, and specifically for our patients that have EGFR disease, right, where they can experience this transformation of histology, which is an acquired mechanism of resistance that we should always check for, and why we always talk about pursuing a tissue biopsy, not always a liquid biopsy, but the tissue to confirm histology. I think there's different ways to approach it, and I've seen different approaches in clinical practice by my colleagues as well, and even from patients that I get from the community centers and what oncologists have done. I've seen typically that patients will not so much be on immunotherapy, but they'll switch to platinum-based chemotherapy, like a carboplatin etoposide, for example. It also depends on where the disease is located. So I've seen some providers maintain the osimertinib, especially if there's intracranial disease. So I think we don't have all the perfect prospective data here to kind of guide it, but I've seen different approaches, and I feel kind of anecdotally that each of them seems to make sense, and it's very individualized. Patient advocacy groups are really important to me, and I work a lot with them. And so I wanted to give a little shout out to a relatively new patient advocacy group and support group specific to patients with small cell lung cancer. So my dear friend, Misty Shields, she is a thoracic medical oncologist at IU Cancer Center. She's worked with Longevity to launch the small cell smashers. And they've just recently been around only for a few months, I believe, earlier this year. And it's been really nice to have a dedicated support group, right? A lot of times our patients with small cell lung cancer get FOMO from our non-small cell lung cancer patients that have all of these very specific patient support groups that are biomarker directed. So just making sure that we have our patients supported is a really big thing.
Absolutely. This is about our patients, and they should feel supported, and all these groups will just make things a tad bit better for our patients. Eric, thank you so much for covering all this in such a short time with us today. Small cell lung cancer still remains a devastating disease. However, advances such as Adriatic study and new approvals such as Tarlatamab continue to provide us some hope. Eric, again, thank you for joining us. For our listeners, let us go over a quick recap. In this episode with Dr. Eric Singhi from MD Anderson Cancer Center, we've covered the current treatment landscape for small cell lung cancer. For limited stage disease, we discussed the role of concurrent chemoradiation, prophylactic cranial radiation, and we've also touched on the recent data from Adriatic study showing improved overall survival with Durvalumab.
For extensive stage small cell lung cancer, the standard of care includes platinum-based chemotherapy with atezolizumab or durvalumab. We also explored second-line treatment options, including lurbinectedin, and then we've also discussed the recent approval of tarlatamab. Thank you so much for tuning in. Be sure to check out our other episodes covering latest in oncology. We are the Oncology Brothers.